At the very soonest. You will have sheep hearts, but they're little and they're kind of depressing. They're all preserved. So I'm going to try to get you guys some on Wednesday, which means that you might not get to do that heart dissection until next week. But it's okay because it's more about seeing it than it is about like being tested off of it. So I'm going to get them for you anyway, even though a lot of you guys won't have them until next week. And then I'll have the lab aides to help with the dissection or do the dissection for you. So sorry, I tried. All right, so let's talk about I think this is where you were. Yeah, the tissue layers of the heart. This is not hard. And then we'll get into the real functionality of the heart today. Okay, and again, what's your name? I don't know your name.
It's Addie.
Addie. So I really want you guys to try to reinforce as we go through today less memorization and more understanding. Like my goal for you will be that when you leave anatomy, nobody ever has to teach you the heart again. You're like, I am going to remember this because it's so incredibly logical. So I'm going to ask you a lot of where blood is flowing, what direction it's flowing, what content it has, all that kind of stuff to reinforce it so that you totally get it. Okay, so before we get into that, let's start talking about what is surrounding the heart and what you would see. So if you cracked open a thoracic cavity and looked in there, would you see the heart? No. Very much like the brain that you wouldn't see because it has the dura mater on the surface of it. You would not see the heart because you would actually see an opaque sac surrounding it. And that opaque sac would be the pericardium with this outer portion, which is dense, irregular connective tissue, same stuff as the dura mater is made of. So the outer layer of this is called the fibrous pericardium, and it's made of dense, irregular connective tissue. And I want to show you what it's like. So the fibrous pericardium, do you see right here that it's actually sort of attaching the pericardium to the diaphragm? So it's like situating it within the diaphragm. And it's also attaching it to the great vessels coming off of the top, right? So it's really positioning the heart within the mediastinum. Does that make sense? So the fibrous pericardium is on top of the pericardial sac that you learned about before when you learned about serous membranes. So you guys remember that the part of the serous membrane that's touching the surface of the heart would be called the what? Visceral pericardium, exactly. And then you're going to have a space, right? And then you're going to have the parietal pericardium, right? So this fibrous pericardium is superficial to that, okay? And it's actually pretty protective and it's hard to damage on accident. Remind me what you should find here in the pericardial cavity. Just serous fluid, right? Serous fluid. So if you're looking at this figure that we were looking at, or this guy right here, the reason that this heart is shiny on the surface is because you are seeing what? Visceral or parietal pericardium? Visceral. You're seeing visceral on the surface of the heart. That makes sense? Okay, so you're seeing the visceral pericardium. Okay, so now if we start moving in, oh, by the way, your textbook decided to try to confuse you. I don't know why the hell they did this, but instead of calling this the parietal pericardium, they decided to call it the parietal layer of the serous pericardium, as if you don't have enough words to know. You don't have to call it that. It's the parietal pericardium. You already learned that. And then this guy right here is called the visceral layer of the serous pericardium, but it's the visceral pericardium, okay? There is one other name for it that you do need to know because it's very commonly used, and it's called the epicardium, which means on the heart. Yes?
So when you're looking at the heart, why are you seeing the visceral pericardium? That's the one that's touching the heart, and it's not the outer layer.
So on this figure right here, on this animation, this whole sac is gone. So you're looking just at the surface of the heart. And remember that with any organ, the reason the organ itself is going to be shiny is because you're actually looking at the serous membrane on the surface, which is the visceral one. Does that make sense? Okay, all right, so now if we go here and start moving in, okay, now we're at the visceral pericardium or the epicardium, then let's take a chunk of the heart wall and make it all the way to the chamber of the heart, right? So look at the tissue that you find on your way in. So the tissue that you find on your way in, oh, before we get into this, does anybody remember what a serous membrane is made of? There's 2 layers of tissue. Serous membranes are made of 2 layers of tissue. Nobody in the last class remembered it either, so it was just like crickets. Okay? Nothing? You got nothing? Even if I wait and make it really awkward for all of us? Nope. Good guess though. Superficial layer is simple squamous epithelium, and then the deep layer is loose areolar connective tissue. Okay, so now let's take a chunk of this and start looking at the surface. Again, we're looking at the epicardium or the visceral pericardium on the superficial surface. And notice you got simple squamous epithelium, and then here, loose areolar connective tissue and fat. Just so you know, as you get fatter, your heart gets fatter. So there's fat that is on the surface of your heart. All of us have a little bit of it. It's just normal to have a little bit of it. But as you start building up body fat and start getting atherosclerosis and those kinds of things, you're going to get more fat onto the surface of the heart. So this layer right here is going to have, this is your epicardium, and it's simple squamous epithelium and loose areolar connective tissue and fat. And then you're going to run into the muscle. Of course, the muscle in the wall of the heart is what kind of tissue? Cardiac muscle, exactly. This layer, collectively, just so you know, if I'm not asking you what kind of tissue, but I'm saying what's the layer called, you have the epicardium, and then you've got the myocardium, right, which is cardiac muscle, right? And now we're moving our way inside, right? So now I'm going to run into, on the inner surface, I'm going to run into another layer of areolar connective tissue, and then the endothelium. The endothelium endocardium. Endocardium is collectively what it's called. So it's areolar loose connective tissue and then a layer of simple squamous epithelium, which is called endothelium. So there's something important to address here. This tissue that's on the inside of your chambers and on the insides of your vessels should be really smooth and slippery. Anybody have any idea why that's important? Yes. Does anybody know what happens if you, for instance, catch a platelet? Yeah, platelets will form inappropriate clots even if there isn't a hole. I always say this, it's going to be offensive because of the audience, but I always say that platelets are like teenagers. You should never let them congregate unsupervised, because what they're going to do, and I say that to my teenagers who flip me off mentally, what they are going to do is as soon as one platelet gets caught, it will attract other platelets, which will attract other platelets, which will start a clot, right? And so you get inappropriate clots. So you need to keep the inner surfaces of your cardiovascular system slippery and smooth. That's one of the many reasons it's a bad idea to start gunking it up with cholesterol. Gunking it up with cholesterol will make you more likely to catch a platelet, more likely to throw a clot and have a stroke or a heart attack, right? So this endothelium has to be nice and smooth. So basically you have epicardium, myocardium, endocardium, right? And then you're in the chamber right there. Does that make sense? So you would be inside any chamber. All right, so now let's start looking at, oh, wait, one last little tidbit. I forgot to mention pericarditis again. Now, we did this way back at the beginning of the semester, but now that you have a little bit more information, you can understand it better. So the fibrous pericardium, again, is made of dense irregular connective tissue. Is dense irregular connective tissue stretchy? No. What's it made of? Collagen fibers going a bunch of different directions. It's like leather or like skin, like the dermis of your skin. So if I start to get pericarditis, irritation or inflammation of the pericardium, I start to overproduce serous fluid. And if the bag isn't stretchy, then where does the pressure go? Onto the surface of the heart, right? That makes sense? And it reduces your filling capacity. And when you reduce your filling capacity, you reduce your pumping capacity, right? And then you reduce your living capacity ultimately. So that's pericarditis again. So we did it at the beginning of the semester, but just more. Okay, so now let's start looking at the actual chambers of the heart. Okay, so gross anatomy, upper chambers, lower chambers. So first thing is obvious stuff, right? The upper chambers are called atria and the lower chambers are called ventricles, and we have known that already. How do you tell when you're an atria versus ventricle? Well, first of all, it's pretty damn easy, but second, there is a landmark right here, okay? This landmark that runs all the way around. Do you see this depression right there between the atrium and the ventricle? It has a name, and it runs all the way around the front side and the back side, and it is called the coronary. Give me a word that means depression.
Sulcus.
Sulcus, exactly. Coronary sulcus. And by the way, coronary, like corona or crown, they tend to run around those vessels. That makes sense? Okay, so that's called the coronary sulcus. It has vessels in it, which we will learn later. We're not going to do them right now, but we will get to them, okay? So it is the boundary between the atria and the ventricles. The atria, I'm going to remind you, are much thinner walled. To me, they feel like skin, and the ventricles are thick and chunky like muscles. Okay, so the atria are thin-walled receiving chambers, and the ventricles are thick-walled pumping chambers. Okay, so we've got the atria. So now let's open up the heart and look. So there is, in a healthy adult, a complete separation between the sides of the heart. And specifically, if we are looking at the atria, there's a complete separation between the atria, and it is called a very logical name, Interatrial Septum. Septum means partition or wall. Okay, so that is that right there. Now, are you going to see it very readily? No. When you get a wet heart in front of you, stick your fingers in it, right? Prove to yourself that you're actually not going to be able to touch if you stick your finger in the right atrium and the left atrium, right? So there is an interatrial septum. Now, there's a structure here which is interesting. In a healthy adult, you're not going to have a hole, but I want you to think about this before we go any further. When you were a fetus, right, do the fetal lungs need any different kind of blood than the rest of the fetal organs? Do they need different blood? Are they functioning like uniquely in gas exchange? Are they pretty much just like a growing organ like anything else? So does it make sense to you that with fetal circulation, you actually don't need a left and a right heart? You can use it collectively as a single pump. And one of the ways that you can do that is that during fetal development, you have an open exchange between the left and the right heart. It's called the foramen ovale when it's open, which means basically oval hole. And here's what happens when you're born. Let's say it's a healthy birth, right? Healthy birth, baby cries, right? That foramen ovale slams shut, okay? And then you get a separation between systemic and pulmonary circulation, right? And when it slams shut, it takes a couple of days, but then it heals. And when it heals, it's a remnant that's left behind even into adulthood called the Fossa of Ballasts. It's a little depression between the left and the right. Okay? Have you ever heard of babies being born with holes in their heart? This is almost invariably the hole that they're talking about because sometimes it doesn't close. Sometimes it doesn't close as quickly, right? If it doesn't close really quickly, they'll just usually give you a few more days to see if it closes. And if it's really, really open and it still doesn't close, then a lot of times they will do some surgical repair later. Does that make sense to you guys? Okay, go ahead.
Sorry, how long can the baby like live without?
Depends on how open it is. If it's really open, right, then you're going to croak if you don't have a good separation between oxygenated and deoxygenated blood. But a lot of us have little bitty, like it doesn't quite seal all the way, so you just get a little bit of exchange. But does it make conceptual sense to you that if you don't have a good separation between oxygenated and deoxygenated blood, your heart is going to have to pump harder to compensate? Because if you're delivering partially oxygenated blood to the tissues, right, then you're going to have to deliver more of it over time. So if you have a big opening and it doesn't ever seal, sometimes they'll go in and intervene. You can kind of understand why they wouldn't choose that very readily, though, because the intervention itself is so damn dangerous, right? You're like, maybe you can just deal with that, right? As opposed to like having heart surgery, right? So that's called the Fossa of Ballasts, and it's a little bit later in your notes, but I thought I'd just tell you about it right now. Okay, so the lower chambers are, of course, much thicker. Let's look at those. It's really easy to tell when you're in an atrium versus a ventricle, right? The ventricles are much, much thicker. I mean, significantly thicker. They are thicker walled. They are going to be pumping chambers. So these are considered receiving chambers, and these are considered pumping chambers. And there is, in a healthy adult, a complete separation between the left and the right ventricle as well, and it is called the interventricular septum. Good? Okay. Interventricular septum. So now, if I have an intact heart, so how do I tell when I'm on the left side or the right side with an intact heart? Now, atria versus ventricles is easy for anyone paying attention, but left side versus right side is not that easy. So first, I want to remind you of what we talked about last time. First, the heart doesn't sit like you'd expect it to. First, it's 2/3 of the mass is over there, and then second, it's slightly twisted, right? So from an anterior view, which side of the heart are you going to see more of? The right side, right? And from a posterior view, you're going to see more of the left side, right? So when you're looking at a wet heart, how do you figure out whether you're looking at the left side or the right side? Well, there are some external landmarks that you can use, okay? And one of them is this guy right here. It's a depression on the anterior surface, and it's sitting right on top of the interventricular septum. It always has blood vessels in it. We'll name the blood vessels a little bit later. But what this is called is the anterior interventricular sulcus, okay? And so if I'm looking at an anterior view, this all over here is right heart, right? Okay, right ventricle, right atrium. Good? Okay, and this over here is left heart, left atrium, left ventricle. Now, it looks, of course, like the left side is much smaller, but it's just because it's twisted. It's really not much smaller, okay? So this is your boundary right here. So if you touch this part, you're on the right heart, and if you touch this part, you're on the left heart. So now let's look at the back side. Oh, by the way, here it is on an actual specimen. So obviously not as pretty when it's not color-coded, but certainly more representative of actual reality. So this is right heart, and this is left heart. Make sense? Okay, now flip it around backwards and try to figure out whether you're on the left or the right side from the back side, and that is here. Okay, this guy right here is called the posterior interventricular sulcus. Good? Okay, and so everything over here is right atrium, right ventricle. Everything over here is left atrium, left ventricle. Good? So you just use those landmarks to figure out where you are when you're looking at the heart. Good? Okay, so got those. Okay, so now let's start looking at the chambers. So really the only challenging thing at all with the heart, understanding the anatomy, is making sure that you always can confirm and be really confident as to whether you're in the left side or the right side of the heart. So there's a bunch of different ways to do it. I'll tell you the way that's really, really dependable. First off, if you have a colorized model or an image, you can use that to help you. But of course, when you're looking at an actual specimen, it's not going to be colorized, so you can't use it exclusively to depend on. So first thing is, let me tell you that, remind me, we talked about this last time. The entire right heart has what? Oxygenated or deoxygenated blood in it? Deoxygenated. And the entire left heart has oxygenated. So here's a way that you can orient yourself. All of the vessels that you see that are blue, all of the great vessels, the big honkers attached to the chambers, those are called great vessels. All of them that are blue are associated with the right heart, right? Because the right heart deals with deoxygenated blood. And all of them that are left are all of them that are red are associated with the left heart. That makes sense? Okay, so that helps if you have color. If you don't, you have to find another way. So let's find another way to make sure that we know when we're in the right or the left heart. Okay, so let's start arbitrarily with the right atrium as a chamber. The right atrium is pretty easy to identify because it has two enormous vessels attached to it. It's got the superior vena cava and the inferior vena cava. So because it's an atrium, which direction is blood flowing through those? It's flowing into the heart, right? Okay, and those are what kind of vessels? Arteries or veins? Veins. Those are veins. Veins flowing into the heart. Okay, now let me give you a big picture understanding, and we will do this in a lot more detail in the next set of notes. Big picture understanding of what the superior vena cava does and the inferior vena cava. The superior vena cava is delivering deoxygenated blood back to the heart from everything above the heart, including my arms, right? Arms and head. So deoxygenated blood back. And then the inferior vena cava is delivering deoxygenated blood back to the heart from everything below my heart. Good? So if I find an atrium that has a big honking vessel, two of them on top of each other, I'm in the right side. Because once you get into the left side, it's a totally different pattern. I've got two pairs that are lateral to one another. Okay? So this is the superior vena cava and the inferior vena cava, and those are both delivering blood into the heart. But see if you can conceptualize this. Students have a lot of trouble with this, so if you don't get it the first time, it's totally cool. So the heart itself, okay, the organ itself needs to be delivered blood. One of the things that I took entirely embarrassingly long to understand is that the blood that is going through the chambers of the heart does not actually feed the capillaries of the heart. Okay, so just keep that in the back of your head for just a second, and let me ask you, if the heart itself, is going to be an organ that gets delivered blood, does it need systemic blood or pulmonary blood? It needs systemic, high oxygen blood. Does that make sense? Okay, so I'm going to have to deliver oxygenated blood to the heart muscle. Then I'm going to have to get it back from the heart muscle and deliver it back into the heart. Okay, the vessel that does that, its opening is right here. It's called the coronary sinus. So let's flip the heart around backwards. So this was everything above the heart being delivered back, right? This was everything below the heart being delivered back. And then this guy right here called the coronary sinus is everything from the heart being delivered back to the right atrium. Does that make sense? Okay, so if you are in the right atrium and you are a really, really good student, you will be able to find the superior vena cava and the inferior vena cava and the fossa ovalis, and you're damn near never going to be able to find the openings to the coronary sinus, but it sure better be there, right? Delivering blood back. Does that make sense to you guys?
So it's the
Okay.
vein,
It's a vein.
but it's also delivering it to them.
No, the other vessels are delivering it to the heart. It's just getting it back from the heart. Okay, we'll talk about the vessels that are delivering it through. On Wednesday, we will do circulation all the way through the capillaries of the heart and show you all of the vessels that are involved. But does it make conceptual sense to you that the heart should be a systemic organ? Like it needs oxygenated blood, right? Okay, all right. So now I've got the superior vena cava, the inferior vena cava, and the coronary sinus. Those can be seen really easily on a posterior view of the heart, although you can see the superior and inferior vena cava from pretty much anywhere. But the coronary sinus, you really can only see it on the back side of the heart. Okay? All right, so now the external feature of the right heart is this little flappy part right here. It's that little flappy part right there. You have one on the left side too. This is called the auricle. This is, the whole thing is the right atrium, but this little flappy part is called the auricle. Auricle means ear, so it looks kind of like a Labrador retriever ear or something to me, like a puppy dog ear. It doesn't usually fill up, but if you're really exercising hard, you can actually fill that thing up and then you can get more blood into your atrium and therefore your ventricles. So that's called the right auricle. This is the left auricle. Okay, so now if I looked at internal features of the atria, let's look at that. So if you look at the internal features of the atria, you've got all these openings. We already talked about that. We already talked about the fossa ovalis. And then do you see that lumpy musculature on the back wall right there? Lumpy musculature on the wall of an atrium, either one, is called pectinate muscle. Now, the right atrium is lumpier than the left atrium for reasons that nobody has ever explained to me. In the left atrium, it's pretty smooth on the wall. It only looks lumpy if you open up the auricle. But either way, if you find lumpy musculature on the wall of an atrium, it's called pectinate muscle. Okay, so now we are going to move through the right atrium, and then we are going to go into the right ventricle, and we're going to meet our first valve. Here's the first valve that we are going, so blood would be coming down here, right, up here, yes? And then here is our first valve. This valve has a couple of different names. You can always call these atrioventricular valves or AV valves because they are between the atria and the ventricles, right? So one way, if you forgot what the hell this thing was called, you could call it the right atrioventricular valve because it is that, okay? But clinically, a more common name for it is the tricuspid valve. So look, cusps are flaps and it's got three big ones. It also might have some small ones, but it's got three big ones. Do you see that? Tricuspid or three flaps, and this one has two. So tricuspid, bicuspid. How do you remember which one's on which side? The way that I have always done it is you try to do right, and then you buy what's left, right? Try to do right and just buy what's left, okay? That works for the valves. It will also work for the lobes of the lungs as well. So try to do right. So that's very commonly called the tricuspid valve. Oops. Okay, so blood is going to be flowing, come back, from here through the tricuspid valve. I'll tell you how the valves work in just a second. And now it's going to be in the right ventricle. Okay, now let's look. The ventricles have the hardest words to spell in the entire semester. So when I'm in the right ventricles, let's look what we're going to find. First off, I have these muscles that are sticking up and holding on to the tips of the valves. That makes sense? And those are, of course, because dirty old men named it, they're called papillary muscles, right? So these are your heart nipples, because you know you have to find everything and name after a boob or a nipple at some point in the body system. So these are called the papillary muscles right there. Okay, you've got them on the other side too, you just don't have as many. Okay, and then what else are you going to run into here? you're also going to run into this lumpy musculature on the wall, way, way lumpier in the ventricles than it is in the atria. And that lumpy musculature on the wall of either ventricle is called nightmare to spell, Trabeculae carnii. Okay? Yep. That's going to be fun, huh? Trabeculae carnii. So the Trabeculae carnii is the lumpy musculature on the wall. And then one more really hard one to spell. And that is these guys right here, these strings of connective tissue that are holding the tips of the flaps to the papillary muscles, right? Those are what people call your heartstrings, or the long name, which is also a nightmare to spell, chordae tendinii. Chordae tendinii. Sound fun, right? Chordae tendinii. And there's two E's in there, and I never can say it right. I'm just like, chordae tendinii. Okay, so now, pectinate muscles, fossa ovalis. So I'll show you a cool picture. So those little guys are fascinating, and we're going to talk about their functionality a little bit later, but do you want to see them in real time, like actually from a heart surgery? Here's your chordae tendinii. Pretty cool, huh? Yeah, that's awesome. And those are trabeculae carnii that you're seeing there, and this is papillary muscles. See them? Awesome. Okay, so we moved through the tricuspid valve. We found the trabeculae carnii, the papillary muscles, and the chordae tendinii. And now let's look at where the blood is going to go from there, and we'll try to put this story all together. So now what's going to happen is the blood is going to move out of this right ventricle into this vessel. And this vessel, because it's attached to a ventricle, has to be a what? Nope. Ventricles pump, so blood will be moving away from the heart. So this has to be a artery, exactly. Even though it's blue, yeah, even though it's blue, right? You don't change gas content as you go through the heart chambers, right? So I'm actually leaving the right ventricle right now. So what's going to happen is when this ventricle contracts, I'm going to push blood into this vessel. This vessel is called the pulmonary trunk because it's delivering blood to where? The lungs. Now let's name this valve. That valve is called the pulmonary semilunar valve. Pulmonary because of where it's going, and semilunar, what does semilunar mean? Half moon, exactly. So those little half moon, do you see why it's shaped, it's called that? Because they're shaped like that. So it's going to go out the pulmonary semilunar valve into the pulmonary trunk, which is an artery. And then it's going to split and go to the left and right lungs. Everybody with me? Okay. And then it's going to do what we talked about last time. It's going to go through the capillary beds of the lungs. Yes? And then it's going to change gas content as it goes through the capillary beds of the lungs. And so when it comes out the other side of the capillary beds of the lungs, should it have high levels of oxygen or low levels of oxygen? High levels of oxygen. Rich, rich blood, and I need to deliver it back to the heart. That make sense? Okay. Now I'm going to deliver it back to the heart, and I'm going to be in the left side of the heart with oxygenated blood. So I'm going to deliver it back to the heart, but in order to see how it gets delivered back there, you kind of need a posterior view of the heart. These two right here, this two pairs of vessels are called the right and left pulmonary veins, okay? And they are going to be delivering blood into which chamber? Left atrium, exactly. And which direction is blood going through them? Which direction? It's going in, right? That makes sense? So I'm delivering blood into the left atrium. Now, that means that it will be pretty easy as long as you can orient yourself to tell the left from the right atrium because the vessels that are attached have such a different pattern. Every once in a while, though, just so you know, some people have 3 and 2. That's okay. It's just anatomical variability. It doesn't seem to matter. Okay, so now delivering blood back into the left atrium. So it looks from this figure like the left atrium is way smaller than the right atrium, but it's not. It's just slightly twisted and then it's smashed back behind all these vessels so it looks smaller, but it's really not. It's about the same volume. Okay, so blood is going into the left atrium. Left atrium has mostly the same structures inside. Pectinate muscles, but they're harder to find in there. It's actually kind of hard to convince yourself how big the left atrium is, so that's one of those another times when you should stick your fingers in there to feel. So blood from the left atrium is going to go through this valve, and that valve has 3 names, okay? And the first one is just logical. You would call it the left atrioventricular valve, right? And that one you always have in your back pocket in case you forget the other two. And then the next name for it is the bicuspid, right? Because it's got two big flaps. And then the next name for it is sort of a historical relic, but it's really commonly used clinically, so you have to know it. So the next name for it is called the mitral valve. And the mitral valve is based on its shape. So way back when in the history of anatomy, if you were studying anatomy in Europe, you were either a Catholic priest or you were dead. Those were your choices, right? Like you don't get to do science unless you're working for the Catholic Church, pretty much historically speaking. So there were a lot of things that were named based on like religious references way back when, and this is one of them. So first off, look at its shape. So do you see how it's got like two little points right there? And then this. So both Catholic popes and Catholic bishops wear this hat. And it is called a mitre. Okay, a bishop's mitre. You ever seen one of those? You ever seen the Pope from the side wearing that hat? They got hats in their religion, dudes. Okay, we didn't get any hats. So if you flip it upside down, do you see how it looks like the mitral valve? Right? So it's a bishop's mitre, so they called it the mitral valve. And that name is still most commonly used clinically. So they talk about, for instance, like mitral valve prolapse. It's based on like sort of the history, right, of that. So that's the mitral valve that you see. So it's got three names. Which one do you need to know? Yes, all of them, because you're going to run into them. You don't want to be ignorant, right? Later, and somebody goes, "Oh, I'm going to talk about this valve of the heart," and you're like, "I didn't know there was an extra one. There's only four." And you got to learn all of them. So this is the bishop's mitre or the mitral valve, right? That makes sense. So the mitral valve. So you're going to go from the left atrium through the mitral valve or bicuspid valve into the left ventricle, right? And the left ventricle is going to start to contract. It's got all the same basic structures on the inside. I mean, slightly different orientations, but it's still got papillary muscles, chordae tendineae, and trabeculate carneae. And so what happens is when this contracts, it's going to go through this valve. Now that valve is the hardest one to find in the heart, just because it's smashed back behind these other vessels. And it's also hard to understand. I mean, it won't be for you guys because you're going to get a really good understanding, but it doesn't look like it's actually pushing blood into that vessel. So what I would do is stick my finger in it to make sure that it actually comes out in the aorta, right? So this vessel right here is called the aortic semilunar valve. Good? Because it's going into the aorta and it's two little half moons, right? And so the blood will go through there into the aorta. The aorta is the biggest artery in the body, and every single bit of arterial blood in all of systemic circulation ultimately can be traced back to the aorta. So all of the systemic arterial blood that goes to your brain, goes to your guts, goes to your skeletal muscles, you could trace it all back to the aorta. So if you got an aortic problem, you got a death problem, unless you take care of it, right? It's like delivering blood to all of systemic arterial circulation. Are we good? Okay. So now, just to sort of make the story a circle, let's just say that we get blood out that aorta. And by the way, the aorta has three sections depending on which direction blood is going. This is called the ascending aorta because blood's going up, right? This is the aortic arch because blood's going over. And then this is the descending aorta. Okay, so let's just deliver blood to a systemic organ. As you deliver blood ultimately from the aorta to a systemic organ, and it goes through the systemic capillary bed, the gas change occurs, right? It comes out the other side of a systemic capillary bed. Is it going to have high or low oxygen? Low. And it's going to have low oxygen. Let's say it was coming from the brain. How does it get back, that low oxygen from the brain, back to the heart? Can you do it? Yeah, exactly. Superior vena cava, and then we're back to the start of our story. Does that make sense? Okay. Ultimately, you will be doing quite a few blood traces by the time we finish this next set of notes, and they're really easy. Like once you get them started, the first one seems like impossible, And then like the fourth one, you're like, this is so easy. You just like change two little things because it's the same circulatory system pattern over and over again, right? You're like, I wonder how I get through the left side of the heart. Same damn way you did the last time. Exactly the same way. I wonder which valve I'm going to encounter. Same one you did last time. Okay, so now let's address the fact that if you look at the difference between the sides of the ventricles, the sizes of the musculature in the ventricles, it can directly tell you which one of them is going to A, generate the most pressure, and B, need to generate the most pressure. So the right ventricle is ultimately delivering blood where? Lungs. How close are the heart and the lungs? Like they're neighbors, right? Okay. So you don't need to generate very much pressure, and you don't need to have a whole lot of musculature comparatively speaking, right? But the left ventricle is delivering blood everywhere. Not only are there a lot of vessels, but some of them are all the way down to my little toe, and some of them are going against gravity and all the way up in my brain, right? So the left ventricle is going to be able to generate the most pressure and also need to generate the most pressure. So if you look at the difference between the sides of the ventricles, it's pretty dramatic. Even a living specimen, or if you do a coronal section, you can see how dramatic it is too. Okay, so I want to talk about valve function. Go ahead.
Sorry, because it has more musculature, does it mean it has less blood that can go?
No, it actually has about the same volume in there. The wall is thicker, but the volume of the chamber is about the same. It does look like it is here, but it's just sort of spread out a little bit differently. They've compared the volume of the left and the right atrium and the left and the right ventricle, and they're like, you know, within milliliters of each other. Okay. Sorry. Okay, now I want you guys to understand in the way that I wish my physiology students understood the valves of the heart and what they do and what they don't do. Because by looking at the valves of the heart, people have these misconceptions about how they behave. Like one of those, like, there. Okay. So if you look at the valves of the heart, you can understand why quite often people look at them and make these assumptions about how they function. So you got the papillary muscles and the chordae tendineae, right? And you can look at that and think, oh, I've got muscles and I got strings and I got a valve. So they assume that what the papillary muscles do is pull open the valves, but that is not how it works at all. I want you guys to have an understanding of how it works. Here is what's going to happen. Valves open and close not directly due to muscular contraction, but due to pressure changes on each side. So here's how we're going to start. We're going to start in the atria. We're going to have blood that we just delivered back to the atria. It doesn't matter whether you start on the left or the right side, but the right side's easier to see. Going to have blood that I delivered back from both my head and below my heart, right? Here's what happens. As the blood starts to pool in the atrium, I start to increase pressure in the atrium. Does that make sense? And look at the orientation of this valve. If it was closed, right, and I start to build pressure on top of it, as the pressure gets high enough, what happens to the valve? It opens, exactly. So it's like the Western swinging doors, right? So I'm going to build up pressure. Now, here's a common misconception. A lot of people think that the atrial contraction is what causes the valve to open, but just so you know, it actually opens far before atrial contraction, and all atrial contraction does is squishes the last 20% of blood into the ventricles. So I'm open, okay? Now I've got most or all of my blood in the ventricles, okay? So here's what's going to happen with the ventricles. The ventricles are going to start to contract, right? And they're going to contract bottom and sides up, right? Increasing pressure in the ventricles and pushing the blood against this side. So what's going to happen to that valve? It's going to shut. But if you didn't have the papillary muscles and the chordae tendineae, it could very easily swing past closed, right? So what do the papillary muscles and the chordae tendineae do? It's like Red Rover. I know I like Red Rover as an example, but what happens is right before the ventricular walls start to contract, send a signal to the papillary muscles and you say, Red Rover, the blood's coming over. And they're like, I got this, right? And they hold on, right? They start to contract before the walls of the ventricles do. And then the walls of the ventricle start to contract. And the papillary muscles hold on so that you don't get a prolapse, which is when you swing past closed, right? So these are not involved in opening the valves. They are involved in stabilizing them when they close, right?
So how do they close them?
They close because of pressure on the backside, right? So the walls of the ventricles start to contract, and then just because of this orientation, you start to push blood against the backside of the valves, and it closes them, right? That makes sense? So now I'm in this position. I just closed the AV valves, and then I have a pause as I need pressure to build up just a little bit more. As the pressure builds up a little bit more, I increase pressure on the bottom of this valve. And what happens to it? It opens, exactly, because of pressure, okay? Now, the hard thing to understand is why the hell it closes. So it's opening, and you squish blood, most or all of it, out into these arteries, right? That one and that one, although that one's hard to see. And here's what happens. As the ventricle gets empty and starts to relax, the pressure drops in the ventricles. You guys with me? But the arteries are full of blood. And so what's going to happen is blood does what all fluids do. They try to flow from high pressure to low pressure. So I got a bunch of pressure in the arteries and very little pressure in the ventricles, and it tries to flow backwards. But look at the cups. What happens? It gets caught in the cups and closes the valve. Right? Does that make sense? So they open and close due to pressure changes. So I just want you to sort of conceptualize this for a second. And now, before we get into disorders of the valves, I want you to ask yourself, which of these 4 valves is going to be most likely to fail you because of pressure? Which one is going to have the most pressure problems? Any idea? This one? This one? This one? Okay, these are not problematic because of pressure, because once you pump the blood into there, the blood goes, right? So they don't stay high pressure for very long, right? It's not like a closed chamber, okay? So your semilunar valves of the pairs are the least likely to go bad on you, although it does happen, okay? Everything that can go wrong with the human body does. But now I just want you to compare the left and the right of the AV valves and tell me which one of those is most likely to fail. The bicuspid. Because do you see how much pressure you're going to put on the backside of that thing? With all of that musculature in the left ventricle, it is going to be undergoing a tremendous amount of pressure. Is that okay? Okay, so let's start talking about when these things fail. First, let me tell you about heart sounds. You probably have heard the heart sounds before. Heart sounds go lubbed up, lubbed up, lubbed up. What are you actually hearing? You are not hearing valves opening. You are hearing the blood slam against the valve as it closes. And you don't even have to memorize which valve is going to close first, which set of valves, AV or semilunar. AV valves close first, right? And then there's a pause, right? Semilunar's valves open and then they close. So the lub is the AV valves closing. The dup is the semilunar valves closing. Lubbed up, lubbed up. The second sound is a little higher, a little more staccato, a little sharper. That makes sense? Okay, so now I'm going to teach you guys about murmurs. So a heart murmur, I have a heart murmur. They can either be AV murmurs when you get inappropriate backflow of blood, because isn't this whole story really about maintaining unidirectional flow of blood, right? Blood ideally should go veins, atria, ventricles, arteries, right? And it shouldn't go backwards or else you're compromising the efficiency of the system, right? But it can, and it does sometimes. And when that occurs, it's called a murmur, and you can hear it with a stethoscope unless you suck at stethoscopes like I do. I cannot hear a heart murmur at all. My cardiologist will constantly go, listen to my heart, listen to your heart, listen to my heart, listen to your heart. And it's just one of those times where eventually you just nod and pretend you heard it, because it's like really getting awkward for all of us. So I'm going to give you a couple of different patterns, and you're going to tell me where the murmur occurs. You can either have lubbed up slush or lub slushed up. Which of those two is an AV murmur? What? Say it, say it. Lub slushed up. Yes, that is an AV valve murmur. And if you get lubbed up slush, you're hearing the it go backwards at the semilunar valves. And then if you are really amazing and absolutely not atrocious like I am, you can even hear whether it's left side or right side. You can hear where it is. Okay, and I definitely cannot do that. So, so let's talk about murmurs and how they occur. Okay, so one reason a murmur could occur is that you have what's called stenosis or scarring of the valve. You know, when you first get a new car, the seals are all really tight and the car's really quiet. But then after summer, winter, salt, heat, all of that stuff, it starts getting loud in your car because they're like kind of calcified and hard and they're not getting a good seal. The same thing can happen to your heart valves. If they get scarred, then they don't get a good seal and you can get a little murmur because of what we call a stenosis or a narrowing and scarring of the valve. And that's what I have. And I have it because I actually had a pathogenic infection when I was a kid. I had scarlet fever and rubella when I was a kid, and it scarred my heart muscles because there were no vaccines for that crap when I was a kid. And now people are like seeing that vaccines occur and deciding not to vaccinate their children because they are just dumb as a box of rocks, honestly. So yeah, I have 2 heart problems because of infectious organisms that vaccines didn't exist for when I was a kid. And one of them is that, and so that's why I've got a heart murmur. There's another reason that you can have a murmur that's a way bigger deal, and that's when the valve is not just scarred, but it actually swings too far back. That's called prolapse, right? So it should go, like with your AV valves, they should do this, and then they should stop. They swing too far back, then you're going to get a lot of blood flow backwards, and that's called a prolapse. And the most likely prolapse is a mitral valve prolapse, okay, because of the pressure that you're dealing with here. And this one got a lot of press, specifically in the 90s. I know some of you guys most of you guys were born in the 2000s, were you? No, you were born in the 90s? Oh, that's right, 90. I have a 17-year-old, I should know that. He's born in 1999. So yeah, but some of us are a decade before that, or maybe a couple. Regardless, there was a really, really famous lawsuit because phentermine and fenfluramine are 2 diet drugs that they tested them independently with the FDA, right? And they worked. But then someone said, oh, if you put them together, they work amazingly well. But they didn't test them together, which generally they don't, just so you know. So they put the 2 of them together, and then they made a really effective diet drug that also scarred your chordae tendineae. And when they get really brittle, they pop. So this happened to my father-in-law. So you got mitral valve prolapse, popped the chordae tendineae, and he ended up having to have a heart valve replacement. And there was major lawsuits because of it, millions and millions, maybe even billions of dollars of lawsuits because of it. And so now what he has is a mechanical valve replacement because of that. And I can sit next to him and hear it go click, click, click. It drives me bonkers. I mean, it must drive him bonkers worse, right? You know, but I can't even sit next to him. Between that and the chewing, I'm like, we got to sit across the room and high-five each other. That's all we can do. So mitral valve prolapse, and these, there were deaths associated with it. There are a lot of heart surgeries associated with it. So that's what a prolapse is. And a prolapse can cause a murmur, but it's far more likely to have just a stenosis cause a murmur. Okay, we'll stop there, and we'll probably finish this next time.